Good afternoon and welcome to our June 2023 meeting of the EPEC Research Project Patient Research Partners team. I am so glad to have you guys together because today I really need your feedback on something that we've been working on in 4 different matters, but they all seem to be leading towards positive conclusion. We just have to figure out how to make this work in a way that is respectful of patients. But let me start by saying it's good to have Harvey back with us.
Thank you. I thought I might have to reintroduce myself, and but now that you hit the record button, because I've missed a lot. But thank you. Good to be here.
Harvey's always right at it, saying, "Hey, I missed the meeting. I'm going to watch the video. I think I got it all. Let's make sure I got what's next." And I'm like, "My guy, like, don't miss a beat, and we won't miss a beat. We'll just keep it on moving." So it's good to see your face, though.
Thank you.
Um, I did want to do just a couple of housekeeping items. Number one, we're at the end of the month. We start doing our timesheets at the beginning of the month. So everybody here and everybody who watches the video, timesheets coming up. Let's be on time. Let's have them ready to go. Um, I Aaron, is there anything else I was supposed to say about timesheets? I think that's it. Just have them ready.
No, just try to get it in, within a week from the first of the month. So you got about 7 days to get it in, and I'll get it processed as soon as possible.
Thank you, Aaron. I'm trying to find the agenda. Aaron, do you have the agenda pulled up?
Well, while you're waiting on that, I wanted to just share with the team that yesterday I had, one of the reasons why I was not here is because I had a little small, brief episode with my kidneys and some issues dealing with that. And so I did a full workup yesterday, and we was waiting on the results of that. And so my kidneys now has completely failed, and the doctor is saying that I have to start back dialysis. So I just told him give me a couple weeks to wrap my head around this, and so I can begin to put in whatever plan I got to put in. So that is where I am at, and I just ask you guys to your prayers, but then at the same time, I don't know if this would affect me still being on the team. I hope it doesn't, but at the same time, that is the journey that I'm about to embark back on.
Well, Della, you look great, girl. And I never want to ask people for updates on their own personal health. I appreciate you sharing what you chose to share with us. Obviously, that is one of our biggest fears. And I'm so sorry to hear that.
We're here for you, Della. Reach out if there's anything I can do for you. Just as a fellow patient, as a transplant nurse, anything that I can do for you, please feel free to reach out. And prayers go with you.
Yeah, I'm definitely gonna do that because I need to shift my mindset to coming from 4 years of transplant, and now I got to go back to dialysis. That's a whole different mind space here. And so I definitely will want to reach out to you, Belinda, so you can just share and help me to be able to make that transition back into that journey a little bit smoother so as I can prepare and put a plan together of now trying to one now and get back on the transplant list, find the right one, and go through what we are here for, and see what I gotta do.
Della, I'm sending you my phone number now in the chat.
Okay, thank you.
And Della, anytime you need to reach out, just talk, vent, whatever. I'm always here for you. And this wasn't the results that we wanted, but if I know you, I know you're gonna get back on the transplant list and you're gonna show them what you made of all over again.
Yeah.
At least you're not going into the unknown this time, Della.
No, and I think that's the headspace that I'm at. Is the fact that before it was unknown. I was really serious. My husband had just asked for a divorce, all that stuff, all hit me, my mom gone. But now this journey here, it's a different journey, but at the same time, the wisdom that I gained over the course of the years of transplantation and everything like that. So the new normal that I gotta present, redo, and I just do feel that I have some family members amongst you and other individuals who I've supported, in their journey of advocacy. So now I have, it's so fun, it's interesting. Now I'm gonna have the experience of doing dialysis for a long time, going to transplantation, now transplantation, going back to dialysis, and then seeing how that headspace really work and what it's gonna really take to be on a transplant list. And the fact that I know, I still deal with the lupus, and because of everything, I now deal with this type 2 diabetes. And so I'm hoping I don't have to go through that, the mind space of what I hear what some patients go through, of seeing like they've been targeted as not a good candidate for a kidney based off of the different issues that they experience that they have. And so that's the first thing that came to my mind.
Well, we're not going to claim that.
No, we ain't definitely claiming it.
Not
And
at
I don't
all.
want nobody to put that on me either. Yeah. So that was that. I'm like, okay, God, you're gonna have to do something with that.
Sounds like you have many advocates, and I'd welcome joining that group. So I'll reach out and send you some info.
Thank you, Harvey. I really appreciate that. So, all right, Ernest. So I just wanted to share that with the team. So again,
I am more than happy to stop recording and start recording again so that this doesn't have to be shared any wider. That's up to you, though.
it doesn't matter. Just keep rolling.
Well, you just a warrior, ain't you?
Yeah.
This in no way impacts your ability to be a part of this project. If anything, it heightens your ability to see this from multiple viewpoints. And that's always been what I have searched for in a patient research partner for this team, somebody who doesn't just speak from one viewpoint or one experience, but multiple, so that when we make decisions and have discussions around the operations of this project, that we are taking in as many different points of view as possible. So
Okay.
as long as you can have us, we would be proud to have you.
Thank you.
Okay. I feel like this is the team. If no other team, then we could be like, all right, and there it is. Let's get to work. we have all had to deal with some hard times with our health. But I will add to the chorus of anything you need. You let me know, especially if you feel like I won't say that on camera. I will text this other part a little bit later. All right, so let's talk about viewpoints. I'll transition there like I'm on Sports Center. Speaking of viewpoints, we went through the surveys for the patients. We're now sitting at 3,800, something like that. But Dr. Sonja and I have gone through the answers that came in, and we've weeded out about 2,700 of those with the expectation that they are bots. We made those determinations based on the longitude and latitude they come from. So if you're coming from Kenya or anywhere outside of the United States, all 50 states, that we would push those out. Anytime that a answer was used multiple times in the open fields, there were some that started with the word reference and then had an answer that was pretty easy for us to spot. Nobody just starts reference. So things like that, repetitive IP addresses. If we saw that, we would check and make sure that that IP address is not associated with a transplant center or a dialysis center. And if it's not, you're probably a bot farm. It was a great deal of painstaking work to figure out those. It leaves us with a little under 1,000, and we are, but Sandra is still working to weed out from there, based on less methodological processes, more of reading each one and saying, okay, it's just hard to believe that somebody that is on dialysis or looking for a transplant or received the transplant would say that everything is not very important or everything I didn't get an answer to I didn't get the information from my doctor, or I have absolutely nothing to add in the two open fields. Just looking at things like that to figure out which ones may be bots and which ones may not. I expect we'll probably cut out another 500. I believe we'll probably end up with somewhere around 400 responses, and that very few of them will be Illinois. Right now, we have very few that are in the Chicago area, and by very few, I mean 20 to 30 right now are from the Chicago area. We went wide with with the with the passing this out to multiple people, multiple organizations that could get it to multiple people. But our goal was always to hear from Chicagoland people and then compare that to what we heard from other localities to say, okay, it looks like here in Chicago, people get more of the information that we expect or less of the information that we don't expect for transplant centers to share. But by having these low numbers right now, and our goal was always to get 300 people from the Chicagoland area as the number of surveys that we get back, and we call it the N in research terms. We are working with some local organizations to see if they can help us get to Chicago/Illinois people specifically. And with Illinois, I would rather have them specifically from Chicago zip codes, but so many of the people in the top half of Illinois are coming to Chicago for their transplant anyway. I feel like it would be reasonable to make that comparison. So Quinn has been helpful in us reaching out to a couple of organizations. We're having conversations with them now, and we'll see if we can get there. But it's definitely did have an impact on our finances that I think I mentioned in the last meeting. But we still. Did you want to say something, Danny? Oh, he wasn't muted. Okay. So we will be redirecting about $2,000 in funding from another budget line to still provide payment to people who take that survey. We still feel they should be incentivized. It's not their fault we got attacked by bots, but to do our best to make this work, regardless of the challenges that we have ran into. So yeah, we're still working on that, but we will not stop the work that we are doing. To that end, we still want to look at procedure 2 because there's a lot of prep work that comes with us getting to procedure 2. In procedure 1, we still have to analyze the survey. We still have to create the questionnaire that goes to the 6 transplant centers where they give us the standard information back and we put it in the EPEC database. But once that's done, we want to immediately start recruiting patients. So while we're finishing up procedure 1, we are talking to organizations about procedure 2, and that's what I wanted to get your guys' feedback on that. So I'll stop there and see if there's any questions or need for clarity from what I've said thus far. Cool. At the last meeting, I was trying to get us to zoom in on one methodology for identifying patients, and the consensus from you guys as well as from the providers was that we should be focusing on every opportunity to bring in participants for this project that we can. That adds some complexity to my job. But you were right, and here's why. I spoke with representatives from AIN, Associates in Nephrology, and from quite a few people from NANI, North Nephrology Associates of Northern Illinois and Indiana. So AIN and NANI are the bigger groups there in the Chicagoland area. And shouts out to Dr. Lerma for helping us get in touch with them. The conversation was around them identifying patients that are new to transplant so that we could enroll them in the project. So because CMS cannot allow that information to go from the ESRD Network 10 to us so that we can contact them, which is direct recruitment. We're looking for indirect recruitment where the nephrology practices would reach out to the patient and say, hey, there's a research study that we think you fit for. Would you like to be a member of this research study? Because that is not direct, obviously. We're relying on other entities to recruit people for us. We it's not going to be standard. We can't, hold Aaron accountable like, hey, did you reach out to these people? It is more about us having a trusting partnership with with an organization that's external to us. So I will absolutely, if everything moves forward as it seems like it will, um, ask a member of NANI to join our team. Dr. Lerma is already a member of AIN, so that if they're going to be part of the research, that they feel a part of the team, because that's just going to allow for us to get a smoother transition of patients coming in. Both organizations were less interested in being transactional in this relationship, and wanting to be able to see this project be a quality improvement initiative for them. Nani specifically has hired a nurse practitioner to help their patients identify what transplant looks like for them, and then help them push through that process. There's also social workers that have been, it's been 6 years since I was with Nani, but there wasn't any conversation about transplant other than the one comment that came from my doctor, and then them telling me I'm not a good candidate. So they weren't especially happy about hearing my experience, though they loved the fact that I have been a Nani patient before and that I'm back to do some work with them, regardless of how I got here. So since I've been gone and the new regulations out of the federal level have made it more palatable for them to get patients, the dialysis patients, into transplant, that they've got their social workers working harder on getting patients into transplant. So social workers are working on it, and this nurse practitioner is working on it. And now here we come saying we want to work on it as well with these unaffiliated transplant professionals. So there was definitely a chorus saying we want to be involved. The bigger question is how. And my terminology is, look, I want this to be as clean as possible. So let's find out what makes it dirty and kick it out. So I'll tell you guys what that conversation was, and then just have you guys riff off of it. I'll take notes. And if there's anything that I need to represent to the nephrology practices, I will. Only patients who are referred from their nephrologist within the practice end up getting to the nurse nurse practitioner that is in charge of facilitating listing for these patients. There's a larger number of patients that do not get referred to and it's just one nurse. I'm not saying this is, giving them a role. It's just one person. I won't say her name because I think I might get it wrong. But it's Tracy. I'm pretty sure it's Tracy. I am going to say her name. Tracy just does as many patients as she can. But the social workers, it is far more rudimentary than Tracy. At least Tracy is a person. She's interacting with you. Not to say social workers are not people, but they're way more in the background saying, hey, you want to be transplanted? Okay, here's a referral. It's still on you to go and do something about that, to make the decision as to whether you want to activate on that referral. When you get Tracy, there's way more um, a conversational / relational aspect to it, some educational aspects to it, and they keep metrics on how well she's doing in terms of getting those patients to the transplant center and listed. So I said, I believe it's gonna be dirty for us to have a patient working with us and working with Tracy, because if Tracy says, okay, regular model, I'm gonna get you to the transplant center that is the easiest to get you to, while we are over here saying easy to get to them, but it's going to be difficult for them to transplant you. And here's why. Here's what the data says. Here's what they've told us is their specialty versus what your specific presentation looks like as a transplant candidate. Um, I believe that that would make it dirty. It might cut out a number of patients um, that would submit themselves to the transplant listing process, but I don't want to interrupt what they've got going on. But I wasn't thinking about this from a patient's point of view. I was thinking about this from a researcher hat on, saying I don't want my data to be dirty. So I wanted to get you guys' opinion on how that might work with us touching Tracy's patients, or do you agree that we should just leave Tracy's patients alone? There's no Jeopardy music. Take your time.
Well, it adds a complication, obviously. You've got I don't know, an educated individual, an individual that's more educated now and not going to be representative of, what the ideal individual, just starting to, the whole makeup of that. So I think you've got a challenge in that it's just not, it's probably a good individual to want to talk to, but it's going to really not be indicative of future people, as to they just are starting and getting information from them, or using them as one of the candidates.
Mhm. Anybody else want to jump in?
Hey, Ernest. Hey, everyone. I'm at the office, so I'm sorry if I stay muted and I'm not on camera. So apologies for that. Just wanted to add real quick, Della, I love you. You know that I'm here for you. So whenever you want to reach out. Also, yeah, I think the goal of our group and similar groups to have educated patients. And I think it might be, I mean, my opinion, right? It might be worthwhile to have someone who's on both sides in essence. So I think it's important to have educated patients sort of speak with their reps sort of on that level. But I also think it's probably good for individuals like ourselves, groups like ours, to sort of get the insight of how that communication is different as an educated a patient versus a patient that's sort of just taking the information as they get it without being sort of like showing sort of a deeper process.
And I want to be careful with that, because I don't want to say that our process is going to be deeper than theirs, or it's going to be more resource intensive than theirs. I do want to say that our process is different from theirs, in that we're not relying on relationships. We're not relying on a rote understanding of transplant centers. We're relying on very in-depth knowledge of each transplant center on a 40 to 50 metric analysis that is done by a physician. And this is very apropos to that conversation we had way earlier. Does that unaffiliated transplant professional need to be a nurse or a doctor? And now that question comes to the fore, because and I'll go back to you, Daddy. If you were the patient and you went through with Tracy and she said go to Northwestern, you went through with us and we said go to University of Chicago. As a patient, what do you do?
Yeah, I sort of wish I was in that scenario when I was going through transplant. I think I think the answer is I would go with the transplant center that best fits my needs, that has all the questions answered that I was looking for, even questions I wasn't looking for. I guess short answer would be like I would be more comfortable being in a unit that's going to work with me and not give me so many barriers without me really understanding what the barriers are, if that makes sense, or what the barriers were per se. Because
It
I mean, in
sounds
a lot of cases, there's sort of information that you're given, or you're given a route that's going to, maybe boost up numbers for transplants. But does that mean that this transplant at this time was right for me? Is this like the deceased versus living donor? Like all that information needs to sort of be thought out, as everyone in this group knows. I just going with a center that's going to give me that information and give me the time to sort of think about it. Because I feel like I was sort of like funneled through in some ways, when I got my transplant at the university. But that could be just my experience in hindsight.
it sounds like you're thinking about it after you've been referred and been at the transplant center and you've had these conversations with them. Remember that our goal is to talk to people before they choose a transplant center for referral. So that level of comfort, that hasn't been established yet. These are all six strangers to you at that point. And I'm saying, I'm your friend and I'm trying to hook you up with a chick. And then you got another friend that's trying to hook you up with a chick. Which of these girls are you going to go on a date with, right? Who you taking to
Yeah,
the Taylor
no, for sure.
Swift concert,
Hey,
Danny?
that's a good analogy right there. I got to tell you, man. And I think part of it too is like the care afterward. I know we had some meetings in the past where we're talking about how easy or how much contact, how much information can I get from the transplant post, the team post transplant, right? I think like hooking up with I'm just this analogy, right? Hooking up with somebody on the front end because of whatever attributes is all good, but what about the long term sort of information? What does that look like for me? Is she a housewife or something else? You feel what I'm saying? Because I think that when you make this decision, once you get in the books, you get on the chair, you get the transplant. Now there's a whole nother level to it, right? And it's just like, what does that look like? I know that these are all strangers up front, but if there's information on the back end that we may have one reason or another, just based off of questions, you might have a better idea of what your aftercare might look like in comparison to just jumping in with anybody, not knowing what that post-transplant life looks like, which is a whole nother challenge.
Let me go to Valinda, then we'll go to Harvey.
You know what? Let Harvey go first.
Oh, okay.
Well, I think a big factor will be who gets to talk to this patient first. And it sounds like that Nani will be able to talk to them first. So they will provide some information, who knows what, you don't know what their criteria is or the process. Maybe you will find out, but you don't know what that is. And so they're, to use your term, they're going to be dirty. They're going to have had something, some information that will, good, bad, otherwise, it doesn't matter. They will have been provided with something that, if you were able to work with the network, you wouldn't have to deal with. And I think that's a challenge. And I don't know what life's tendencies are, but you, I'm thinking of myself. I'm often influenced by something. The first time I hear about something and they tell me X and someone tells me Y, X has already been in my mind, and may be hard to change that. So I just, the more the conversation goes, the more I start to feel like it's not a good cohort.
Jen, so Harvey.
Go.
My first thought is, Ernest, from a purely research statistical standpoint, it almost sounds like, using the nurse practitioner group, you're going to end up with like a mixed sample instead of, a homogeneous sample of patients that you're working with. So that was my first thought. You went to talking about, information provided by physicians versus those from nurses, from nurse practitioners, PAs, what have you. It's well documented that patients trust nurses way more than they trust physicians. And so, while there's a group that will trust the physician simply because they have the title physician, there's way more patients who trust the words that come out of a nurse's mouth. They're the constant in their care. The physicians are in and out, but when you are going through your workup, when you're, post-transplant, it's the nurses that spend the most time with you in clinic. They're the ones that spend the most time with you on the phone if you have an issue. So I think having a nurse or a nurse practitioner, has its place. But I just wanted to put that back on the table, that it's nurses that patients trust, particularly when they're trying to make a decision. Whether you're on the floor, you're going to talk to your nurse. Yeah. Because your doctor's going to be in, out, bam, gone. The same thing with nurse practitioners and PAs. They are in that medical model mindset. They're in, they're going on. It's your nurse on that you're dealing with, whether it's clinic, whether it's pre or post transplant, whether it's, on whoever's on call over the weekend. That's who you're going to spend the most time with. So that's my 2 cents worth. And then from a quality standpoint, I think that there are some opportunities to treat this as a performance improvement plan. So I'd be happy to, talk more about that later as well.
I think the information that is being shared both by Danny and Belinda is definitely something to take into account. But I want to jump on what Belinda just said about the nurse practitioner, because in oftentimes, especially when you go to these small, I don't want to really say small, but more so these private practice doctors, even though I know they do clinic and they do rounds inside of the actual dialysis facilities or whatever, you might as well say, generally it's the nurse practitioner that we do have the more interaction with. And oftentimes when, like, even now in my care, that's who I've been speaking with in the initial pre-op and been doing the work. And then of course, now that is at this level, of course, the doctor is now even more engaged. And you do tend to build up a connection and a relationship with the NP to the point where that when you really need to reach your team, if it's an issue or whatever, they'll be the first line of contact versus me directly getting the doctor. But when you're talking about I'm just now learning about this whole idea concept about transplantation, transplant, and then, wanting to be considered and whether or not if I qualify along that line. The thing is, you're going to be more engaged with that nurse and to try to help you in communication than I feel with the doctor. But then when you start thinking about who is really a more qualified candidate, I think when you're looking at labs, records, and all that other stuff, that's what interferes a little bit in relations to like the referral of, is this person going to really truly be a good candidate for a transplant and everything along the line. Because I know for myself, that's what happened, because they knew I had lupus. And so automatically I was in this check label of like, I don't think that you'll be a good candidate type of thing. And so it forced me to have to go out there and do research about transplantation, and then trying to find the right center. How I found University of Chicago is once again was due to the fact that I knew that they had a very strong lupus research team at the time when I was looking. So that's what drew me to them. And then from there, over the course of time, they start opening up instead of just strictly being PPO, HMO, and that's how I was able to get in and working with Dr. Josephson, of course, who's on our team, and then some other people. And the
So
nurse
so let's
practitioner.
stop
Yeah.
there because we don't want to get into after you got referred. We want
Oh,
to
okay,
stay
yeah,
focused
right. So
on
right there, I'm just
that
saying
piece to get
there,
into it.
yeah, I needed to.
So I hear you guys' point. Um, and while I agree, Danny, we want to give people as much information as we can. That is a maxim, but we do have to kind of be concerned about the research, because if we don't get clean data, we can't really say that this worked. And if the patients, I'm not that dude, because I will trust the doctor more. But if there's more patients out there that would trust what the nurse is going to say, that remember that our intervention is talking to the doctor, but our metric of success is how long it took for that person to get listed. And if they end up going to a transplant center that won't take them because that's what the nurse practitioner said versus them listening to what we said, then our number gets dinged because they listened to somebody else as opposed to us. Not saying that that would happen every time, but any one time that it happens, especially if we were going to do 350 people, and now because we're doing indirect recruitment as opposed to direct recruitment, I'm expecting we're only going to see about 200 people go through this instead of the 350. That it's going to be even more important for us to try to hone in on patients that we can help navigate. I see you unmuted, Quinn.
Yeah, so I've been breathing Chicago air and albuterol all day. So I just want to make sure I'm clear on what's going on. So, hey, so we have 90, right? Who are going to get to these patients quick just because of who they are.
They have not signed any data use agreements or subcontracts as of yet, but
So
they
let me
want,
fix
they say they
potentially.
potentially, yes.
And their method is basically having a nurse practitioner who works with the patients and kind of guides them into transplant programs, correct?
They also have social workers that
social.
are doing it, but the intensive intervention is with that nurse practitioner, Tracy. Yes.
Got you. So where this project fits into there, they will be able to help us, will help with.
They would be able to help us with identifying patients that are new to dialysis.
But they've already had this conversation with them beforehand, right?
What conversation?
Well, they've already talked to the nurse practitioner, the social workers.
So the nurse practitioner, probably not, because it's a minority of patients that are talking to this nurse practitioner.
Right.
But most of the patients are talking to the social worker, but it's not nearly as in-depth a conversation. It is not an education. It is you need to be on the list. Quite frankly, even now, I'll say this on camera because they said it. There is an incentive for the nephrology practices to have these people on a transplant list somewhere if they can easily get them onto a transplant list somewhere with the changes to regulations on dialysis facilities. So Most of them would probably have had some conversation with the social worker, but not all of them will have talked to the nurse practitioner.
Ernest, can I jump in here as
Let me have Quinn finish her, because I see she's going somewhere.
I
She
was
just
just
ain't
trying to
got there
answer
yet.
that question. Go ahead.
So no, I'm asking these questions for clarity, but if she's only taking a minority of these patients, that means we should be able to get to the other group of patients, right?
True.
So that means that's more people that we're able to give.
In-depth counseling on what transplant center is appropriate for them.
I'm so glad you're like a little thing in my head that's able to pull out the information. Yeah, essentially that's what I'm trying to say. So if that's the way it's set up, then I can see some of the, I can see it work.
Go ahead, Valinda.
I was just going to say, typically the way that, from a strictly regulatory standpoint, the incentive that the social workers have, the dialysis centers have, is, first of all, it's a CMS requirement that they educate all patients on dialysis of their modality options, whether that's in-center hemo, home hemo, nocturnal, peritoneal dialysis, no treatment, palliative care. There's the transplant. They're supposed to let them know the whole range and then let that patient decide. So then the patient says, okay, thank you very much for this information. I think I would like to pursue a transplant. It's at that point that they make the referral. They are incentivized to make as many referrals for transplant evaluation as possible, because that regulation has been in place for a long time. They're just now holding their feet to the fire as a metric, and measuring, are they in fact doing that? So that's where their incentive is coming from. But it's always been a requirement to provide that modality education. Yeah. So I just wanted to provide some clarity on that.
I think we're all getting to the place that I was at when the call ended. That, and I got there as a researcher. So I think Harvey was thinking very much as a researcher in all of his responses. But this does end up cleaner for us as researchers, but I think it also ends up cleaner for the patient. If we say, if the doctor has referred you to this nurse practitioner, awesome, go talk to that nurse practitioner. In terms of a quality improvement program for the organization, for them to compare what she's done to what we did with a totally separate group of patients, that's valuable to them. Just as a comparator for, well, maybe this is what we should add to her role, or maybe we need to have the doctor more involved in this conversation because it looks like they're having better luck with this than we are in transitioning patients to it. Or maybe just the fact that Valinda is talking to every one of these patients, and Valinda is a transplant recipient herself, that is the golden ticket, and that peer counseling is something that we need to be focused more on. Whatever it is that the patients on the end say, this is the thing that made me want to switch, and we had a 67% success rate while that nurse practitioner is having a 50% success rate. It's a value add for them to understand what that change is. There was something else that Harvey said that I wanted to come back and touch on, and now I forgot.
Maybe this will tickle you, or I don't know what the incentives are, but I'm going to guess that NANI has there's a financially larger incentive for them than the social worker at the dialysis clinic to get a referral or someone on the wait list, et cetera. I don't know what those numbers are, but I'm going to guess the incentives are better for nanny.
The incentives are for the dialysis facility. It's just that most of these doctors, most of these nephrologists work in the dialysis facilities. So it's worthwhile for them because some of those dollars flow back to them.
Mm-hmm.
That wasn't it. but I'll take it. So God, I should have took a note because it was, I know I wanted to talk about it, but it is what it is. So we haven't gotten this deep into the conversation with AIN, but I believe that that's the path that I would like to see us take. And we'll have, as usual, we talk about it here, and then we talk about the same thing at the grander meeting next week after you guys have had time to digest a little bit more and say, you know what, I got another reason that I think this is the right way to go, or I had a chance to think about it and now I want to stand firmly on everybody should have the opportunity to talk to that. Oh, I remember what it is. Only patients who are being referred by their physician are having the conversation with Tracy. So if your physician does not deem you transplant material, then you don't get to Tracy. You don't get that additional service. Obviously, it could be that, you know me, I go back to BMI. It could be that that doctor thinks your BMI is too high, but that doctor doesn't know about UIC. It could be, and this is something that they came up with. It could be that that doctor just doesn't like Black people, and that doctor is not referring his Black patients. When they said that, I thought like, y'all got some data you're not referring to right now, but there is something to be said for us getting more difficult to list patients. And I welcome that as a challenge based on all of the work that we're doing for an entire year, getting ready to put something together that is substantial, that is well researched in terms of the 6 transplant centers in Cook County. I relish the opportunity to say the doctor might not think you're a good candidate, but let's talk to this other doctor and see what he says based on this litany of information that we are giving. Because those doctors have to take care of their patients. I don't expect for them to be reading every little article that comes out on the transplant centers and what they can do based on the 7 years ago, the last time that you talked to somebody from that transplant center. I would like for you for the patient or participant to be able to have the most up-to-date information, and that maybe we're able to show them, regardless of the physician's understanding of what makes a good patient or not, no patient should not get the resource that you're providing to only some patients with Tracy, with that doctor as a gatekeeper.
Can I add to that, Ernest?
Yes.
You know, when you made your comment, first thing I thought of is it's not only biases in referrals for or to get listed. There are biases to even get a referral period for evaluation. So we've got that bias. We also there's a bias we haven't talked about is there are physicians who don't refer to programs or other physicians because they don't like the person or they don't respect them professionally, which has nothing to do with me as a patient.
Very true.
So
Very
I
true.
just want to put that out there, that there are some explicit and inexplicit biases that play into that have absolutely nothing to do with the patient or what's in the best interest of that patient.
The thing that I said to them was, if your doctors are acting off of anything that is not an absolute contraindication for transplant, then that's malpractice. And they didn't like to hear that from Ernest. But you cannot tell that transplant center what they can and cannot do. If they have said, I won't take anybody that is schizophrenic, then fine, don't refer anybody that's schizophrenic. But to say, I think your mental capacity might not be there, but the transplant center didn't say anything about your mental capacity, then you refer that patient to the transplant center and let the transplant center make that decision. Right now, they're saying, I think you're a good candidate, so I'm going to send you on.
But then that gets us right back to transparency and individual transplant program selection criteria. Period.
Exactly. It's why we're here.
And Harvey, I'm sure with your work, this is mental health is a huge issue for living donors, because I've seen that in selection. They are terrified of transplanting or doing a donation of anybody that has a history of suicidal ideology, severe depression, severe anxiety, those three at the top, where it could have been situational. That situation has been resolved, but they still get that label. And they're terrified because someone somewhere wrote an article about a patient who subsequently committed suicide, and they don't want that on their record. And that's not fair to the patients coming behind that. They're just not willing to take that risk, because you just might on one bad day get hit by a bus, kind of nonsense. It's like, okay, if you've been dying, we keep talking about in this country, and I'm digressing a little bit, but about how we need to put mental illness and mental issues front and center and treat them, but yet and still people still get penalized when they go for life insurance because you have had a history of a mental illness. I mean, you can't have it both ways. And I think the same thing is true in transplantation. And I'll just leave it at that for today.
I love Belinda on her soapbox, boy.
I was just gonna say, she preached that one, didn't she?
Unfortunately, she's got a lot of experience with it.
Yeah. So again, I haven't talked to AIN. I expect, because it's a smaller practice, I don't know that they'll have a Tracy, but if they do, I think we stay in the same vein. I certainly hope that by saying, don't give us Tracy's patients, that we're not self-selecting for patients who don't want transplant, right? And that's something I said to them in the meeting. Don't send us only patients who have said no, or don't send us only Black patients because we're looking at the South and West sides, and that's what you think is on the South and West sides. Just let's make this a procedural task that everybody that is within this certain group, the people who didn't go to Tracy, are who gets it to us. And because we're absolutely not going to get every single one of them to be a member of of the work that we're doing. So let's not self-select on our end, and let's not have any of your biases from the nephrology practices work their way into who they send to us and who they don't send to us, just to make Tracy look better or whatever. Obviously, I need to find a better way to say that, but it is a fear of mine that it didn't click to me until after I got off of the call, that There's always a way to put your finger on the scale, and I want to make sure that we move away from that. That's probably something I open up more in conversation with the larger team next week. But you guys have a preview to it, for those doctors. What is the process for the larger team, I should say, for us and them? What is the process that we feel should be put in place to say, here's how these patients get to us, so that the next time I meet with Nani and AIN, we can have something to present.
Ernest, based on what you just said, would it be something for us to consider that if there are patients that are being referred, what did you say her name is Tracy?
Yeah.
That she then deems are not appropriate to refer for transplant to wherever whatever their process is, maybe those patients then get referred back to the study. Just another avenue to look at, if they've decided that, for whatever reason they don't move them along, maybe it's because those patients need that unaffiliated professional to look at their records and say, based on what their usual habits are for referring, they have high BMI, so they don't refer them on. Maybe that's a patient that needs to come back and be evaluated, for a center that does take high BMI or that does robotics, if that's not part of their, her work.
You are right. I am thinking as the PI that has to have good relationships with these organizations. What I don't want to do is question her efficacy as that resource within their practice. So if the doctor refers the patient to Tracy, and Tracy says, I can't get this patient listed, I don't necessarily want to say she's wrong. Give them to us.
Well, then maybe the approach is, because we've talked about working with them as a performance improvement project. I've got my quality hat on now. Is maybe maybe the improvement piece is her better understanding the resources that are available to that patient with a high BMI that she just isn't as comfortable or knowledgeable about, where that patient can be referred, and add that to her toolkit of knowledge to know that for another patient like this, I can refer them on to this program because they do robotics, this program because they do take higher BMIs.
I see your point. It seems to me that that Tracy is well placed within that organization. That perhaps she was doing something else and got promoted because everybody kind of had a smiling face when they talked about Tracy. But this role,
the best centers have new things that they always discovered that they didn't know.
You're right, and the performance improvement, the quality improvement would definitely come after we are done.
Right.
We come back and say, we got the 67%, she's getting 50%. Here's some things that the patients told us that you should include into what Tracy's doing. To come out ahead of time and say, there's a possibility that Tracy isn't where she needs to be. That's a threat to Tracy, right?
No, I would never propose that.
No, for us to say, send us the patients that Tracy didn't get to the finish line, it insinuates that, right? I'm not saying you're saying that on purpose. I'm saying, as an administrator with some people from the outside coming into my practice, that's how I would say it. That's how I would see it. I would see it as, no, Tracy's doing a good job. Okay, I hired Tracy. I know Tracy's doing a good job. Let Tracy do her thing. You can take these other patients, or you ain't got to. You can go on your merry little way and find your patients another way. But I hear your point. I would stay away from that.
And I
Um,
hear
and-
that too, but I think whether it's at the, you know, the analysis part of the project, but at some
Mhm.
point we have to look at, were there patients who ended up not getting referred that probably could have or should have, and how could we
From Tracy's cohort.
and
Okay.
how could we have helped those patients? How can we still help those patients after the fact?
Absolutely. Yeah. You examine that 17%, right? If we're getting 67%, she's getting 50%. What's going on with that 17% that she didn't get? And here's something that we're doing on our side that might work for that side. I agree with you on that.
You know, my analogy would be those drug research, you know, protocols where they stop it early because they see that it's a very effective drug and they don't want to continue, so that the patients that are not being treated with that drug can receive treatment. To me, that's a similar analogy. But even if we
Mm.
do it on the back end, I just don't want to see a patient not get referred and not get transplanted just because we were afraid to say something. And
Mm.
and I can appreciate it from a research standpoint, but from a nurse and a fellow patient, I don't want to see one patient not get transplanted just because we're afraid to speak up.
Belinda just pulled my card. I ain't scared, Belinda. Okay.
You
I'm
can't
not
blow
scaring
up
you,
the
Ernest.
spot.
I'm not scared.
No, but that leads to a good thought that she blow up the spot. So what? Using your example,
Yeah.
what if Tracy isn't referring patients simply because she doesn't think, I'm not going to say that word, overweight people should get a transplant?
Mm.
And you don't know this until it all comes together and it kind of, you know, shows, and then that gives them an opportunity to go back and give her education and resources about, hey, it's not about what you think. These are the programs that can transplant those. So I'm kind of with Belinda on this one.
Okay, well, I have to say one more thing behind that, Ken, is that, you know, as a nurse practitioner,
Mhm.
she has a lot of latitude depending on the state and her licensure practice act, what she can do and decisions she can make independently. But for the most part, she's still working within a protocol that is approved by those physicians that she's working with. So if we look at that, if the issue is we're still getting the biases of those physicians, if it's written to their
Mhm.
protocol not to refer those
Mhm.
patients with high BMIs, she's only
Mhm.
following protocols. She may personally, as a nurse and a nurse practitioner, think I should be referring this patient, but I can't because of the constraints of my protocol. So
But there is no protocol. I did confirm
there
that.
she has to have a protocol to work from.
No. They refer that patient to her on a case by case basis.
No, I'm
And
saying
once that
there's a protocol that she works within. She's got to have a scope that is agreed upon that they're going to support her in. She's
I you're right, but that's administrative. That is not operational. In this instance, when we're talking about a nurse practitioner in a pain clinic, and this is what you can prescribe and this is what you can't prescribe without talking to us, then you're right. But for this is consultation. So once that person gets referred to her for consultation, it's not like she could turn around and say, you're not a good candidate. You've given me that patient. I have to figure out what I can do to get this patient on a list, unless that patient says, I don't want to be on a list. So they were clear that she has latitude to send them where she wants. They don't send it and say, I want this patient to go to University of Chicago. They send it to say, this patient can go here or there. Now, there might be a back door that says, hey, Tracy, in the lunchroom, if I send you a patient, all of my patients go to Northwestern. So I don't care who I send you, you send them to Northwestern. That could very well be a case, but that's, we're here to solve one little problem. We cannot jump in and try to fix those issues.
just for clarification, so the patients that they are referring to Tracy in her
Mhm.
role as a nurse practitioner are
Mhm.
patients that they have already deemed transplantable
Right.
or eligible for transplant referrals.
Right.
So
That
there's
they feel are good candidates for transplant,
right.
which
So
is rife with bias, right?
so
We
they
can all agree
right,
on that.
right. But let's roll with it. They're referring those patients they deemed okay to refer for transplant.
Mhm.
And they're okay to whichever program she refers them to. Or let me rephrase that. Once they've referred a patient, it's not going to be a situation where she's coming back saying, I don't think this patient is eligible for referral.
That is what they told me. They
Okay.
said that
Okay.
is the understanding.
So based on that, every patient that they send to her, we can, I hate to use the word assume, that she's going to refer them someplace. For
That is the
transplant.
procedure that is in place for NAMI.
Okay.
Yes.
Okay.
But that doesn't mean that all those patients are going to say, okay, great, let's go.
Oh,
So if,
absolutely. But she has
right.
the latitude to refer every single patient that they send to her.
Yes. Yes.
Okay.
I feel like every single time we go over, and I apologize, but we always have such great conversation. Right? I need to make the update shorter at the beginning so that I can get you guys out of here on time. But I love sharing with you guys. I love you guys pouring back into me. It makes me better. So thank you. I really do appreciate these conversations. Any parting words before I let you go?
Just to reiterate, Della, we got you, girl.